The Table Talk podcast, where no discussion about the dinner table is off the table.
Hello everyone, and welcome to the 6th episode of EDAC's Table Talk podcast. My name is Kyle Buchan, the Research Assistant at EDAC, and today I'll be talking to dietitian Clare Ellison. We'll be covering multiple topics, including establishing the difference between a dietitian and a nutritionist, as well as talking about how Clare has implemented autism-affirming practice to work with autistic clients, and we'll be placing a particular focus on those with ARFID. I really hope you enjoyed today's episode, and thank you so much for tuning in. Okay, well, thank you so much for joining me, Claire. Lovely to have you. And I guess before we get started, it would be great if you could just introduce yourself, maybe who you are and kind of what you do.
Yeah, of course. No, thank you for having me. My name's Clare Ellison. I'm an advanced eating disorders dietitian, and I've got a history of, working with individuals with eating disorders across various settings and age ranges, and also with a sort of strategic research, operational, clinical leadership experience. So I actually currently work for the North Cumbria Provider Collaborative, and then any direct client work that I do is sort of privately at the moment. But initially, that provider collaborative role was as a regional ARFID project lead, but it's now the Eating Disorders Service Improvement Lead, and that still very much includes ARFID. I'm also the dietetic clinical advisor to the National Eating Disorders Charity BEAT, and a member of the British Dietetic Association ARFID subgroup committee as well.
Wow. So, yes, I'm surprised that you made the time to do the interview today with all that going on. So thank you so much. So you mentioned, amongst all of that, there was the word dietitian in there. And I wonder if we could just kind of go in a bit deeper into kind of what actually is a dietitian. And I think some people hear the word dietitian and kind of also hear nutritionist as well. And there is a key distinction there. So I wonder if you could just maybe explain that difference, and I don't know, maybe kind of tell us a bit about what that role looks like in your day-to-day life.
Yeah, sure. So it's a really good starting point, isn't it? Because you're absolutely right. I think the two get kind of intertwined, but they are very different. So in the UK, I guess the key difference between a dietitian and a nutritionist lies in their regulation, qualification, and their scope of practice. So a dietitian is a legally protected title, and that means that only those that have completed HCPC approved training and are also registered with the HCPC, which is the Healthcare Professions Council, can call themselves dietitians. So it's a regulated profession. That means that registered dietitians have to meet strict standards of education, training, professional conduct, and then within our scope of practice, dietitians can diagnose and treat dietary and nutritional problems. So that means that we're also able to prescribe dietary treatment for the management of medical conditions. Now that is different from saying that dietitians can prescribe pharmaceutical products, because only a few advanced practice registered dietetic prescribers could fulfill that role. But it does mean that we can prescribe structured dietary management plans, such as meal plans for the treatment and management of eating disorders. Nutritionists, on the other hand, are not a legally protected title, and technically anybody can call themselves a nutritionist regardless of qualifications. And I guess qualifications within that can vary widely, from incredibly short low-level courses to really very credible, robust degrees in nutrition science. And there is a registration for nutritionists, but it's voluntary, and many do choose to register with the Association for Nutrition, and that sets sort of professional standards, but it just isn't a requirement to do that. So because of those differences, the scope of a nutritionist is kind of limited from being able to treat medical conditions or prescribe those prescriptive nutritional plans. Does that make sense?
Yeah, no, that's a very clear distinction between the two, and I think it is really important as well for kind of, I suppose, people that might actually be seeking out these services as well, to really understand that difference and to kind of know what to expect and maybe who they're getting as well. So no, thank you, that's really, really helpful. So obviously I imagine you work with kind of as you said, a vast range of people, and with kind of different eating difficulties, whether that's kind of eating disorders or feeding disorders. Today, I think for the kind of the topic that we want to talk about today, we're going to focus on avoidant restrictive food intake disorder, or ARFID. And so I guess it's helpful for those who haven't heard that term, like, what do we mean by that? What's kind of what behaviours are associated with that? And maybe how do you distinguish that from picky eating? We hear that term quite a lot. But yeah, there's a distinction there.
Yeah, no worries. Well, we'll start with what is ARFID, and then we can think about the other one. Because you're right. I think understanding is still quite limited, or it can vary. So ARFID stands for avoidant restrictive food intake disorder. So it's a diagnosable eating disorder, and it's classified, say, in what we call the DSM-5 and the ICD-11, like diagnostic manuals. So it's characterised by a persistent and a significant avoidance of or restriction of food that leads to what we call clinically significant health or psychosocial impairment, or both. So unlike other eating disorders, ARFID isn't driven by concerns about body image, and it's also not an exclusively low weight disorder as well. So say an individual could have such a narrow range of foods that they are very nutritionally compromised, they might be severely deficient, and they can still be of average or above average weight, and that's because those few foods that are accepted could be really energy dense or like high in calories. And I guess you mentioned about like what behaviours there might be. So within ARFID, there are, say, 3 commonly described but diagnostically unofficial subtypes. So that means those are, say, that restrictions stem from like sensory sensitivities, or a fear of aversive consequences, so things like choking or vomiting, or just a general disinterest in food and eating. And those subtypes do also often overlap or interlink. And then as well as that, ARFID is sort of frequently seen in individuals with neurodevelopmental conditions like autism, or those with other mental health difficulties like anxiety, as well as co-occurring physical health conditions such as like gastrointestinal issues or allergies. So that's hopefully, I think, what ARFID is. Is there any questions about that bit?
No, I think that's great, and it's so difficult, like you say, to pin it down. I think in terms of getting a succinct definition, because, like you're saying, there are all of these kind of presentation differences that. Yeah, it's just difficult to kind of get a succinct description of it. So I think you did a very good job there. And you did mention, I think, and this is potentially controversial, but would you say that you class ARFID as an eating disorder, or would you class it as a feeding disorder, or does it matter to you? Because I know there's kind of, I think in the ICD-11, I believe it's classified as a feeding disorder, and then in the DSM, I think that eating and feeding disorders are kind of all lumped together. I might be mistaken there, but I believe that's true. But I know that recently ARFID has picked up kind of a lot of traction within the eating disorder space. So I think it was chosen for this year's Eating Disorder Awareness Week by kind of a few organisations. So yeah, I wonder if you have an opinion on that, and if you think there's kind of clinical significance either way.
Yeah, sure. I quite like that you said it might be controversial, because in so many ways I think it is. But yeah, I can definitely talk on that. I also have remembered that I haven't answered about picky eating and ARFID, so let me come back to that later.
Yeah, no worries.
But yeah, so in terms of the kind of classification, I do think there is a significant difference between the two. And I guess as yet, I'm kind of unconvinced that one is the correct argument or lens over the other. And I agree with what you said. It's confusing because DSM-5 lists ARFID under feeding and eating disorders, but ICD-11, which is what we typically use in the UK, is putting it under eating disorders. So as you describe, certainly in the UK, there's a lot of traction, isn't there, within eating disorder services, research, etc. And I think there just are benefits and risks of both. Like, if ARFID is viewed more as a feeding disorder, then it tends to include multidisciplinary feeding colleagues like occupational therapists, speech language therapists, paediatric feeding specialties, and I think it can help to normalise the condition in young children and avoid mislabeling them with like psychiatric disorders too early. And I think as well, it probably considers the oral motor skills developments and deficits a little bit more fully. But conversely, if ARFID is classified as an eating disorder, then the treatment focuses more on multidisciplinary psychological approaches, and it can sort of better acknowledge, I guess, that ARFID can affect adolescents and adults. And that's really important because ARFID is increasingly recognised across the lifespan. As well as that, I guess labelling ARFID as an eating disorder might help to validate the experiences of psychosocial and mental health impairment more fully, and potentially reduce stigma for patients who have like serious nutritional issues but no body image concerns, and who are like facing significant and very difficult psychosocial impairment as a result of their difficulties. So I guess in a nutshell, I think there is a difference, but that there is a value to both approaches, and both have the same sense of shared aim, and that it's likely that regardless of someone's age, a needs-led like holistic approach which recognises the combined skills of everybody in a system and then seeks to address the presenting clinical need according to that individual person is just ideally the way that development should go.
No, absolutely. And I mean, to kind of see what the like community themselves views it as, like as a whole. If if there's and I don't know if that's been done, maybe I need to look into that, maybe someone has done that, but just to get us kind of an overview of if the kind of people with ARFID generally consider it to be a feeding disorder, or if they maybe identify more with an eating disorder label. That would just be interesting.
Yeah, I agree. To the best of my knowledge, I don't think that has been done, but there is a study there that needs doing.
Yes, I'll make a note of that. There might be something we can do. Yeah. And I suppose quickly before I move on, to as you rightly pointed out, I kind of accidentally skipped over the previous question I asked you, which was like that distinguishing between kind of ARFID as a diagnosable condition, and then kind of picky eating, and where the kind of difference lies there.
Yeah, I kind of really wanted to answer that one because I just think it's so important. So I suppose like in autistic individuals, like both ARFID and picky eating can be like influenced by many factors. So sensory sensitivities like beliefs, routine, interoceptive differences, loads of others. And the distinction between the two lies in that understanding of, say, degree and consequence. So picky eating, or selective eating, as I think myself and many others prefer to call it, can be, say, viewed maybe as a continuum or a spectrum, and then to a degree it's like almost everyone lies somewhere on that continuum. So say from just liking one or two foods with absolutely no nutritional or social consequence, and then you might move on to maybe disliking like whole categories of textures with no real impact, and then you might move into, say, avoiding or restricting many foods such that like that forms an intake which seems, say, significantly different, really restricted, but is one that we might call like minimally safe. And then past that on the continuum is what we call the clinically significant severity thresholds that we see in ARFID. So I guess we think about it another way. It's sort of like teasing apart autistic people who have highly selective intakes from autistic people with ARFID is essentially about the understanding of difference versus disorder. And I suppose there's like a few points that are important in that conversation.
No, absolutely. And I think, that is just super helpful. And I also do agree, selective eating is definitely a better term. I use the term picky eating and kind of, people can't see my fingers, but in air quotes. I think, there's so much frustration amongst autistic people when their behaviours are labelled as that by often non-autistic people that like haven't experienced those kind of, like you're saying, like sensory sensitivities or interoceptive difficulties, whatever it may be. So I think that's really important to highlight that as well. So thank you. Now, working with autistic clients, I suppose an important thing is building trust and kind of making sure that you build that rapport. So, I mean, how do you personally go about doing that kind of specifically with autistic clients? Like, is something that you do differently? Or, it'd just be interested to kind of hear what the process is. Yeah,
sure. I mean, the therapeutic relationship is going to be really important with anybody that you work with, whether they're autistic or not. But in answer to the question of are things different? Yes, everyone's different. So I guess the starting point for me is that I'm not autistic. So with any person, it just feels like absolutely essential that I take the time to understand them and then validate their experiences, say without judgment, and just crucially without holding any assumptions about them or their story. And I suppose because like nutritional change is really hard, like it's very long, it's very anxiety provoking, it's very difficult. So I suppose if I'm expecting to help somebody through that, then they absolutely need to trust me. And that trust, you can't command it, like it has to be earned. And it is fairly obvious, but I guess that's through respect, it's through listening, like integrity, honesty, openness, professionalism, and just really taking time to ensure that that person feels heard, like understood and then valued as a very unique individual. I guess within autism specifically, like being sensory aware helps. So finding out what works best for them and making adjustments to be as accommodating as possible. Also about communication preferences and how best I support their understanding, but also my own. Understanding like any communication barriers or adjustments that could be helpful. I think building predictability is important. So things like explaining what a session could look like in advance, sticking to appointment routines, giving notice if things are going to be different as far as possible, respecting boundaries and pace. And as I said, because change is so difficult, it's kind of important to ensure that like you build in strategies and tools that work for them in managing like any arousal or distress that can be resultant of that process, so that they feel psychologically safe in that very difficult process, and that you have really spent enough time understanding all of that and that individual person before moving on to the change work. And I guess there's just one more specific thing I think that's really, really important with autism, everybody, but very much with autism, with those with autism, which is recognising, I guess, that autonomy can feel really deeply threatened and unsafe through that process. And so being flexible and adaptable in my approach, so that there is kind of collaboration in like every aspect, and so that the agenda that we're working to is really led by them, I just think is so important.
Absolutely. And I mean, without kind of sounding condescending, I'm like very, very impressed by the amount of, it sounds like you've really got a big autism background there in terms of your understanding. The amount of adjustments that you're clearly making is just, I think, probably a far cry from a lot of autistic people's other healthcare experiences. Speaking to autistic people, there's oftentimes there's no collaboration, like you were saying, and there's even no kind of one of my favorite things that you said there was when talking about communication, and it's not just about kind of placing the onus on them in terms of like understanding what you're saying, but also like to make sure that you are also understanding what they're saying and really respecting and acknowledging that kind of two-way process. So yeah, I think that it sounds like you're honestly doing an amazing job, and yeah, like I say, I'm sure people listening will be kind of very pleased to hear all of that going on as well.
Thank you very much. It's very unexpected, but very, very nice to hear. It's always difficult, isn't it, to know if you're on the
absolutely,
on the right line. So appreciate that.
I suppose like kind of on a similar line, but maybe just kind of getting a bit more specific, is kind of how do you personally balance respecting kind of preferences, so whether they're kind of driven by sensory preferences or whatever it may be, how do you balance that with also kind of encouraging that dietary variety or kind of ensuring that we're getting adequate nutritional from diet? I just wondered if there's kind of something that you do, or
again, back at you. I love these questions. So I think this is like this is a really important question as well, isn't it? So for me, I guess you start with a place of acceptance and validating a person's food preferences without judgment. Like understanding that the goal here is about building on those. It's not about removing or changing the safe aspects of the diet at all. And from there you kind of move on to like prioritising the nutritional gaps. So so as I kind of said before, like change is really hard. So let's not change for change's sake. Let's look at the clinical priorities. What is really important now? And that could be important for the psychosocial or emotional well-being of that individual, or it could be to reduce physical risk or harm, or both. But what is the priority? And it is also possible that, say, I can hold priorities from, say, a risk and health point of view, and who I'm working with can hold different priorities. So you do have to balance that out as well and think about within that which one is still the most important. And I guess once we've got that, then we can use and build knowledge about like what might be scary. Why? What are the sensory and environmental profiles, or what might be like past negative experiences that we're dealing with? And then you use all of that information to guide you towards a direction, a collaborative direction, shared direction of where to start. Because from there, you can then best use things like food training techniques or exposure experiments. And as long as you've done the pre-work before, you know that you're going to be starting at the most possible and the least difficult place. And the one that's hard, that's like the priority, that's the most important. And then, as I said before, you pace match, you respect autonomy, you support a consistent and support predictable presence. So I suppose just to reinforce the message that I'd mentioned sort of before, about minimally safe intakes. So minimally safe is like a concept which is determined by science and nutritional safety. And it has got absolutely nothing to do with what I or anybody else thinks is socially or culturally varied enough. And that's what I was kind of alluding to before with the disorder difference thing. We have the right to food preferences. We all have the right to food preferences, and we all have the right to make different choices. And I think it's that frame is the thing that best helps you to respect preference, but also encourage change, if that makes sense.
No, absolutely. And I think it's just really interesting hearing it framed like that as well, because it's one of those things that you forget that it's so ingrained in culture, and it's such a social thing as well, that you almost take that element for granted, actually, and then you kind of strip it back and like, of course it's people have the right to have their food preferences that don't necessarily fit the kind of the wider social narrative. So I think that makes a lot of sense, because I've not been familiar with that term, minimally safe, and I think it's really interesting, I'm sure, for people listening as well. So yeah, thank you for that. That was really cool.
Yeah, no worries. I mean, it's essentially that like we all, don't we? We all have the right to preferences, whether that's food choice, volume, the way that meals like look, or they're put together, or the times that we eat, or our pace of eating. Like, and within, as you said, within that frame of like inverted commas, it's really hard on a podcast. Inverted commas, normal. Are all those kinds of biases, like you said, culture, food beliefs, expectations, social norms, etc. Like, we all have the right to be different, and then to find like our version of what works and what feels comfortable. And so working out nutritional priorities or distinguishing ARFID from selective eating just comes from like that understanding of the nutritional profile. And dietitians are really, really good at that, because sometimes an intake can seem more unsafe than it actually is without that expertise. And then you unpick like the understanding of the impact of that difference. And then, as I say, nutritional, psychosocial, physical consequences of that. Because that is how we determine what is minimally safe and different, and the right to be different, and what is absolutely okay, and then what is less safe and what needs work and what we can help and support with. And there's just probably one more point on that, if I can.
Absolutely.
Which is just to kind of say that like ARFID isn't static or permanent, whereas difference can be. So because I guess ARFID hinges on those like clinically significant thresholds, or the thresholds of clinical significance, then it is possible to move in and out of like an ARFID threshold, like say in times of like vulnerability, like, I don't know, changes or crisis or trauma or something like that, and then move back out of it when things become more possible, or you've worked on it, and then you move back into that position of safe difference. So yeah, there's a lot of nuance there. I just want to make sure that it's difference doesn't mean disorder.
No, absolutely. And I think, again, it's really important to maybe for people who don't have feeding difficulties themselves. I think that's actually quite an important thing to kind of recognise, is that it's not as black and white as kind of just being disordered. It is like dependent on kind of like you say, stress levels at that time, things that are going on in that moment, and yeah, so I do think that was kind of a really important distinction to make. Now, lastly, because we've kind of heading up to our time, but I guess as a researcher, my kind of thing when I have these conversations is always like, say, what does research need to do? Like, how can we take this conversation forward? How can we help people? And I guess, yeah, from maybe a dietitian's perspective, like, what research do you think is kind of missing, or that you would like to see done, that could really have kind of clinical significance for kind of specifically the kind of autistic ARFID population?
Yeah, we already found one, didn't we?
Yes.
But I guess just like going back to like the earlier question about, say, feeding difficulties versus eating disorder, I think there's a real opportunity to explore more research into the like effectiveness of team-based approaches, and then coordinated care across services. So that joining together of like mental health services, eating disorder services, pediatrics, feeding specialists. And then I guess I'd probably also like to see probably more diagnostic clarity and potential like subtyping. So maybe research to refine diagnostic criteria, develop validated tools that might distinguish ARFID, especially from like other feeding or eating challenges, particularly in neurodivergent and learning disability populations. And then maybe one other would be pharmaceutical options or approaches for, say, appetite stimulation or those disinterest presentations.
No, absolutely. And I really also like that you kind of mentioned learning disabilities in there as well, because I think they're definitely part of this conversation.
Mm-hmm.
Although, like, not often in the conversation, but it does definitely apply to them. And we're obviously at EDAC, we're really looking to include more people with learning disabilities in our research as well, because it has been kind of historically a population that's not necessarily been given like a stage to kind of tell their story. Mm-hmm. So yeah, I think that's really good that you mentioned them. Thank you so much, Claire. This has been like really, really interesting. I'm sure that everyone listening will agree as well, and I definitely have learned some things today, which I'm going to look into some more after today. So yeah, thank you so much, and I hope you enjoyed speaking today.
Yeah, no, my pleasure. Thank you so much for having me.
And that brings us to the end of episode 6 of the Table Talk podcast. I just want to thank Claire again for taking the time to speak to me today. I know that she's incredibly busy, so it's really, really appreciated. And to everyone listening as well, I just want to thank you for your continued support. We really do appreciate it. As always, if you have any questions or comments about the podcast, you can contact me on my email address, which is kbuchan@ed.ac.uk, and I will do my best to make those happen. And yeah, that's it. Until next time, bye bye. Thank you for listening, guys.